Nursing care related to psychological and physiologic changes in pregnancy. The goals for this lecture is to list the signs of pregnancy and describe the psychological and anatomic adaptations in pregnancy. What are some of our psychological changes? Well, first, regarding social, today pregnancy is viewed as a healthy span of time, best shared with a supportive partner or the woman's family. Women bring their families for prenatal care visits as well as to watch the actual birth. Culturally, how well a pregnant woman and her partner feel during pregnancy and are prepared to meet the challenges of this new responsibility brings is related to their cultural background, as well as their personal beliefs and their experiences. A woman's cultural background may strongly influence how active of a role she may want to take in her pregnancy. The family in which a woman was raised can be influential in her beliefs about pregnancy, and she may have individual differences. A woman's ability to cope is based on her individuality and how she's going to adapt to the stress of pregnancy. Psychological tasks by the woman and her partner is first, accepting the pregnancy during the first trimester, second trimester, accepting the fetus, and third, preparing for the baby and the end of pregnancy. And actually toward the end of pregnancy, they may even feel a little impatient. Emotional responses. Well, grief. She may be grieving her prior lifestyle before becoming a parent. Narcissism, known as being self-centered. This is when a woman focuses on herself, and it's really for protection of her fetus. For example, she may be involved in some type of sport, and the physician says, yes, you can still continue to play the sport safely, but she may refuse to because she feels she may harm the baby. Introversion and extroversion. Introversion, or turning inward to concentrate on oneself and one's body, is common during pregnancy, but some women may actually become extroverted and be more active and appear healthier than they ever have. They may also have to deal with body images and boundaries. And during stress, because pregnancy brings with it a major role change, it can cause extreme stress. Depression. Depression can cause as many as 14 to 15% of women may have depression coming into a pregnancy. And then they can develop it during the pregnancy. What our concern is with that is that a lot of the meds used to treat depression is teratogenic. So that's something we definitely have to screen for. Cuvade syndrome is an emotional response by the partner. This is when the partner starts having symptoms of pregnancy, nausea, vomiting, weight gain. Emotional lability, there may be mood changes during pregnancies, changes in sexual desire, and if there's existing siblings in the household, there may be changes in the expectant family. The older siblings are going to have to prepare for the new baby. There are events that can make it difficult to accept a pregnancy, such as if the pregnancy was unintended, there's more than one fetus, the woman's relationship may be ending as a result of the pregnancy, there may be a major illness. So what are the physical changes of pregnancy? We're going to review presumptive versus probable versus definitive. Presumptive are symptoms that are taken mostly subjective. They're reported by the woman, but it's something that the examiner documents. So it's more of a subjective finding. First is breast changes. Breast changes, the woman will report feeling tenderness, fullness, tingling, enlargement, and darkening of the areola. Nausea and vomiting, that's related to the hormone HCG. Amenorrhea, she'll report that she's no longer menstruating. and she may report frequent urination, and that's the result of the enlarging uterus on top of the bladder. Probable signs, which are objective, these are signs that the examiner can actually see. First is Hager's sign, that is softening of the lower uterine segment, right here as we see in the photo, and right here, softening. Goodwell sign is softening of the cervix, uterus, and vagina during the first 4 to 6 weeks of pregnancy. And Chadwick's sign is bluish discoloration of the cervix, vagina, and labia during pregnancy as a result of increased vascular congestion. A later probable sign would be ballottement. This is about 16 weeks. That is when the lower uterine segment is tapped on a bimanual exam and the fetus can be felt to rise against the abdominal wall. Another probable sign is a positive pregnancy test. This just tells us the woman is producing HCG. That can be detected by urine or by blood serum levels. Now, if they're done by blood serum, we can actually get a quantity amount, and based on that quantity, we can estimate how many weeks pregnant she is. HCG is produced by the corpus luteum, which produces the hormone to help maintain the embryo and fetus until the placenta can take over producing estrogen and progesterone. Now, the reason it's considered probable instead of definitive is because you can have a molar pregnancy, which is reviewed in pregnancy complications, and a molar pregnancy can produce HCG without actually having a fetus present. A low HCG level, based on how many weeks we estimate, based on her last menstrual cycle, might mean that she's possibly miscarrying. She may have an ectopic pregnancy or a blighted ovum. A high level of HCG means we miscalculated her pregnancy date, or she has more than one fetus, or she may have a molar pregnancy. Quickening. Prima gravida is a woman who's first time pregnant. She might perceive fetal movements between 18 and 20 weeks. And multipara is a woman who's had at least who's been pregnant at least once. She would feel it at approximately 15 to 17 weeks. Braxton Hicks are contractions, or they're practice contractions. They're frequently felt after 28 weeks. And how we distinguish false labor, known as Braxton Hicks, versus true labor is that Braxton Hicks will disappear with walking or exercise. It's actually the uterus practicing to go into labor is what Braxton Hicks is. The more pregnancies a woman has, the earlier the Braxton Hicks come on. Positive signs of pregnancy, fetal heart tones, very important. Remember that fetal heart tones by Doppler can be detected at 9 to 10 weeks from last menstrual period. Another positive sign is fetal movement felt by the examiner after about 20 weeks. And last would be if we actually see the fetus on an ultrasound. This just reviews the different signs we just went over. Presumptive symptoms of pregnancy. And these are some of the physiologic changes that go on during pregnancy, and we're going to go over them one by one. First is the uterine changes. The most obvious alteration in a woman's body during pregnancy is the increase in size of the uterus. This great uterine growth is due partly to a formation of a few new muscle fibers in the uterine myometrium. By the end of the 12th week of pregnancy, the uterus is large enough that it can be palpated as a firm globe under the abdominal wall just above the symphysis pubis. By week 16, it's midway, and at 20 weeks, it should be at the umbilicus. Now, about 2 weeks before the term, about the 38th week, for a prima gravida, a woman who's in her first pregnancy, the fetal head settles into the pelvis and the uterus returns to a height of 36 weeks. And that settling into the pelvis is known as lightening. Now, if she's had children in the past, she may not light until she actually goes into labor. We also see additional changes. Amenorrhea is absence of menstrual flow and occurs with the pregnancy. She may also have cervical changes as we have those increased level of circulating estrogen. The cervix becomes more vascular and edematous. And again, we can pick up on signs such as Goodell's sign. We also can have vaginal changes from the estrogen. And an increase in the vascularity of the vagina parallels the vascular changes of the uterus, and we will see changes in color to deep violet, which is known as Chadwick's. And vaginal secretions before pregnancy have a pH value of greater than 7, which means it's alkaline, but during pregnancy, the pH level falls to about 4 or 5. This helps make the vagina resistant to bacteria invasion during the length of the pregnancy. Ovulation stops with pregnancy. And then we have our breast changes. Subtle changes in the breast may be the first physiologic change that is obvious to the woman, and that would be the tingling and tenderness. But as the pregnancy goes on, the areola gets enlarged and starts to darken. And the breast, as she gets into the third trimester, will continue to grow in size. We also see endocrine changes. Almost all aspects of the endocrine system increase during pregnancy to support fetal growth. First, we have the pituitary gland. A major change in the pituitary gland is the halt in production of FSH, follicle-stimulating hormone, and luteinizing hormone. We went over those hormones when we went over women's reproductive health. At the same time, there's an increased production of other pituitary hormones, such as growth hormone and melanocyte hormone. That does the skin changes such as chloasma, which is the mask of pregnancy, and the linea nigra, which is the dark line that goes from the umbilicus down to the symphysis pubis, and we're going to see pictures of that soon. We also have an increase in prolactin late in pregnancy, third trimester, because that helps aid in when lactation after the fetus is born. We also see an increase right near term, near 40 weeks, of the posterior pituitary in its production of oxytocin. Oxytocin is the hormone which helps contract the uterus during labor. Now, the thyroid gland enlarges to produce increased levels of protein-bound iodine because the woman's basal body metabolic rate increases by about 20%. With that enlarged thyroid, we are also going to see some emotional lability, and she may get some increased perspiration. However, the parathyroid gland, which is necessary for the metabolism of calcium, also increases because calcium is important for fetal growth. Adrenal glands increases in pregnancy. It adds additional levels of corticosteroids and aldosterone. Remember, aldosterone now will help hold some water, and by holding sodium in water, it's helping to keep the blood volume. That's its purpose. It's protectant of the woman's body. So she has enough blood volume to nourish the placenta in the uterus. What it does is The aldosterone plays a major role in promoting sodium reabsorption, so there is enough adequate perfusion. The pancreas increases the production of insulin because we have higher levels of glucocorticoid being produced by the adrenal glands. However, insulin is less effective because of the placental hormone, the estrogen, and the progesterone. They are all antagonists to insulin. So basically, the woman becomes insulin resistant. And that plays into gestational diabetes. Which is in this slide. Increased insulin responds to increased glucocorticoids and our placental hormone, which is known as HPL. It decreases insulin effectiveness. Okay. What are other additional changes? Our immune system in pregnancy, the IgG goes down, so there is an increased risk of infection. However, it's counteracted by the increase in white blood cell counts as protection. Remember that it's not unusual, especially after a woman delivers. We always do a CBC after delivery. She has a very high white blood count. It could be as high as 25,000, and it's not a sign of infection. It's part of the body's way of protecting itself. Skin changes, we might have striae gravidarum, which is layman's term known as stretch marks. Diastasis is when the abdomen separates right here after a woman has a baby. Sometimes if she's had this happen, when she attempts to lift her head up like in a sit-up, you can see that area of separation come up right there. Linea nigra, that's from that melanocyte we were discussing, and chloasma is darkening of the skin on the face. Also, approximately 1 in 300 women might develop what we call PUPS. It's pruritic urticarial papules and plaques of pregnancy. It's really itchy. It starts off on the abdomen. We don't see it on the umbilicus, and it starts to spread out. And it's very itchy. And we just do conservative treatment until after delivery. Respiratory changes, even though we have this growing abdomen, their lungs actually increase in their ability to hold a breath or tidal volume. That's why even though we may have a woman who's pregnant and asthmatic, we really don't get that many asthmatic attacks. But if she does have them, it will be between 24 and 36 weeks. Other changes that we see, cardiac output, she is carrying about 25 to 50% more blood during pregnancy than she is when she's not. So that's going to put a lot more, it's going to cause the heart to have to pump more. And in fact, that's why it's not unusual we might have a functional murmur or estuary during pregnancy due to that increased cardiac output. Her heart rate will go up slightly, increase in blood volume, red blood cells. We have also an increase in fibrinogen. And again, leukocytes, 20,000. Now the fibrinogen is increased because it's meant to help protect the woman when she delivers the placenta and aid in the healing of the uterus. And blood pressure might decrease in the second trimester. Again, increased blood volume. She's also going to need increased iron and vitamin needs. Remember that we promote, before getting pregnant, increasing our folic acid because it helps prevent neural tube defects. And again, heart might have a functional murmur or an estuary. Blood pressure decreases in the second trimester. We also have decreased peripheral blood flow, so we may see edema to the lower extremities. And also, it can result in hemorrhoids as a result of varicosities to the rectum. We'll have increased clotting factors in white blood cells. Now remember, those clotting factors like the fibrinogen, fibrin, and platelets, pregnancy-induced hypercoagulability. It's a physiologic adaptive mechanism to prevent postpartum hemorrhage. But because they have this increased fibrin and platelets, it puts them at risk for developing clots as a result. Also, some of our changes include supine hypotension syndrome. That is when, as the fetus grows, if she were to lie on her back, that fetus will put pressure on the inferior vena cava, and as a result, it decreases blood flow to the extremities and the return of blood. So this can cause cold and clammy skin, feeling faint, becoming hypotensive. And also, if you're pressing on that vena cava, it prevents blood from nourishing the placenta. So that can cause fetal hypoxia. What we do is we tell them, if they have to lie down, lie on your side, preferably the left, and that they should get up slowly. We also see in the GI system, early in pregnancy, they have nausea and vomiting. That's again related to that hormone HCG. The growing abdomen and the hormones helps relax the pyloric sphincter, so they're prone to developing GERD. Dental hygiene and tooth decay is possible. It's related to the imbalance within the mouth. And peritonitis is associated with preterm birthing and low birth weight. That's why they highly recommend good dental care while pregnant. The urinary system, remember the aldosterone, we're holding fluids. So that's going to increase the glomerular filtration rate. And it can put pressure with the growing abdomen and uterus on the ureters. Now, during the second trimester, even though the uterus is growing up to 12 weeks on top of the bladder, and it can increase urination, once she gets into the second trimester, it starts to pull out of the pelvic area, so she doesn't have that issue of increased urination. But then in the last trimester, when the baby drops, it falls back on the bladder. So then again, she's going to have pressure. Now, the other things with the pressure on the ureter is that it can put urinary stasis, and that puts her at risk of not only UTIs but pyelonephritis. Remember, UTIs, very important, are a risk factor for preterm labor. Now, in the average woman, if we are just colonized and we don't have symptoms of a UTI, they don't treat with antibiotics. But if they are pregnant, we do treat asymptomatic bacteriuria, which is bacteria in the urine, in pregnancy. And we treat it with nitrofurantoin and cephalexin because they are safe during pregnancy, or they're class B. Pyelonephritis is, the signs and symptoms are fever, nausea and vomiting, and flank pain. And this is usually treated in the hospital with IV antibiotics. This is just reviewing the urinary changes during pregnancy. So let's just ask a couple questions. Which of the following tests is most important during the first trimester? And in this pregnancy, before a fetus moves, we're adjusting to just the fact of being pregnant. A pregnant woman lies on the examining table. She grows very short of breath and dizzy. The nurse recognizes which is the probable cause, and we just went over this not too long ago. And it's going to be C. Blood is trapped in the vena cava in a supine position. And that's why we tell her to lie to the side, preferably her left side. Blood volume normally increases during pregnancy. How much does it increase? 30 to 50%, and that's why we can get a functional murmur, a functional S3. She's pumping a lot more blood, but remember, because she's pumping a lot more blood, if she were to have a hemorrhaging situation, she's going to have to lose a lot of blood before we actually see changes in vital signs, because she has that extra blood. A woman during her first trimester questions how much longer she will have urinary frequency. What should we advise? Okay, read our choices. And it is common in the first and third trimester, and I explained that's because in the second trimester the uterus comes out of the symphysis pubis, takes off the pressure, but when it drops again in the third, she'll have increased urination again. That's the end.